Well, good evening, everyone, or good afternoon, depending on where you are. I'd like to welcome you to a Viva Learning presentation. Our topic tonight is dealing with oral cancers, lumps and bumps and red and white things in people's mouths. And as dental practitioners, it's an issue that we do face in our practice. I know we all come from different viewpoints. Some of us tend to do more type of surgical procedures than others, and we'll treat this kind of broad and open in that regard. I think many of the procedures that we'll talk about tonight can certainly be undertaken by a general practitioner that is comfortable handling some minor surgical procedures in their office as well too. So it's not an exclusive type of a presentation. As you see on the title slide, I do practice oral surgery here in Avon, Connecticut. My email address is there. And if someone wishes to contact me afterwards, certainly feel free to do that. So we'll start off here. And we also want to make a couple of quick appreciation to Perel Pharmaceuticals, manufacturers of Orablock, who are the sponsors of tonight's program. They do produce Articaine in both 1 to 100,000 epinephrine concentration, as well as 1 to 200,000 epinephrine. So thanks, Perel, for supporting our continuing education in our field. So these are the types of things that we're faced. Some things, as we'll see tonight, are fairly obvious, and the patient may be bringing them to our attention. In other cases, we may find that's something that we pick up, or perhaps our hygienist does pick up during their evaluation of a patient. So as we deal with these, we're dealing, not only with issues of the patient management, but also managing their concerns, because obviously the threat or concern of cancer is quite significant to our patients. The other side of the coin is we don't want to overlook something that, as we'll see tonight and today, that early diagnosis is really the key when we deal with oral malignancies. And so we are at the forefront of that. And in some respects, we're kind of lucky because oral carcinomas, oral cancers, malignancies occur typically on the surface of the tissue. And so therefore, it oftentimes is easy for us to see. Now, certainly it may be hidden behind the tongue, behind the retromolar pad region, but it's up on the surface and not very deep in the liver or in some areas such as that. So we need to make a diagnosis, and yes, some things are very obvious. Yep, if you see a baby, we know it's a baby, and sometimes things are very obvious to be malignant lesions, but it's those areas in between, those gray areas, that really give us a little bit of work. So we're going to talk a little bit about the art of our differential diagnosis. We know many things that appear in people's mouths are reactive, in other words, due to biting on their tongue or biting on their cheek, a burn with a hot pizza, some other type of an agent as well too. We'll put ourselves and our patients through what we call the diagnostic sieve so we can find these things out. And there will be common lesions that will present to us, and sometimes they're referred in by medical practitioners, they're physicians, because they take a look in someone's mouth very quickly and somewhat of a cursory examination. All of a sudden they see something and they'll go, oh my God, look at that, and get the patient upset. So it's not an uncommon referral in our practices, I'm sure you've seen as well, where the patient calls up somewhat in a panic that they saw their primary care physician or a nurse practitioner. They saw something in the mouth and they're very concerned about this bump. We know it's an exostosis, it's a torus that's been there for the last 20 years, but all of a sudden it's a little irritated, it looks a little bit more nasty, and the patient and the physician is very concerned. Cysts and tumors of the jaw bones, the maxilla and the mandible, are sometimes a little bit more discreet for us to see. They may be picked up on routine radiographic examinations, and certainly when we take radiographs, we are responsible for interpreting the entire field of view. We need to correlate that with the clinical presentation, and a lot of things will not require any specific treatment. I think where we get the most concern are the mixed red and white lesions that occur inside the patient's mouth, how those are presenting, and then what type of management they are. Of course, infections overlay. We're also familiar with, and as a whole separate topic of a conversation that we won't have time to go through tonight, is the medication-related osteonecrosis of the jaws, or the response to the bisphosphonates or other anti-resorptive medications that patients take. And when that bone gets exposed, and I'm sure we've all seen it in some form in our practice, it looks quite ugly, quite concerning. But as we know, it in itself is not a sign of a malignancy, but more of a reaction to the bone turnover being blocked. And then there it is on the bottom, the cancer and the malignancy. That certainly is a concern for us all. So we start, of course, with a good patient examination and patient history. Some of the questions that we're going to ask our patients on a routine basis, of course, is smoking history and alcohol consumption. And as we'll see, these two factors are quite critical and play a major role in increasing the risk of an oral malignancy occurring, particularly what's called a squamous cell carcinoma. And a squamous cell carcinoma is one that starts on the outer surface or the epithelium or mucosal surface, and then eventually will invade into the deeper tissues and then down through the lymphatics through local and what's called local and regional spread to the lymph nodes of the head and neck region. So when I see a patient like this, and we see our patients in our offices, of course, the question is, had you noticed that before? And sometimes it's quite amazing that you can have a lesion of this size, and patients will say, no, I never really noticed it. It does look bad when you point it out to me, but in general, they're not aware of it. And it's sort of a characteristic of a malignant lesion, oftentimes are non-painful, because as the tumor invades, it basically affects the nerve endings in that area, and therefore causing lack of pain and discomfort. The other side of the coin is to say, oh yeah, I was drinking a hot coffee the other day and I hit my side of my tongue, it really burned and a big blister formed, and it's looked really bad, but actually this looks even better. Obviously that's a positive sign, and we'll talk about how we follow these types of cases along. So we need to talk about risk factors, and of course smoking and alcohol use are something that is not new to us. We're all aware of it. We know that smokers are 3 times more likely than non-smokers to develop a mouth cancer. And people who smoke and drink alcohol, as you see there, the risk is up to 30 times greater. Now, alcohol consumption in this regard is more than 3 drinks per day on a daily basis or every day during the week. So perhaps the highly involved social drinker on the Saturdays and Friday nights may not have the increased risk, but certainly when you combine that with smoking, that's where the problem occurs. And again, you can see here that about 90% of those who get cancer of the head and neck, including oral cancer, use tobacco or spend time around secondhand smoke. So that's an interesting concept as well, too, that the patient themselves may not be a smoker, but they may live with somebody who is a smoker as well. And also, it's different, when you smoke cigarettes, obviously your risk of lung cancer, your risk of damage to your lungs, developing COPD, et cetera, certainly occurs as the chemicals in the cigarette smoke damage the lung tissue. But with oral cancers, it's the direct effects of the smoke on the tissues itself. So it's not getting into the circulation or in the bloodstream. So whether it's a cigarette, whether it's a cigar, we certainly are aware that non-smoking tobacco, such as snuff or chewing tobacco, also contain risks. Pipes also are high offenders, and pipe use seems to be subsiding a little bit in our society. But it's interesting that when the constant presence of this pipe tip with the tobacco and the nicotine and other carcinogenic agents there, we would see a much higher increase in those. And one of the questions that we'll probably learn more about over the next few years as marijuana use increases, as recreational use increases, I shouldn't say improves, and medical use increases as well too, is that we may find indeed that marijuana smokers may also be more likely to develop oral cancers. A question also comes up now, and it's sort of an unfortunate part of our society, is about vaping. So e-cigarettes do contain carcinogenic components. They're not entirely safe. Again, it's out of our scope to discuss what happens in the lung and other areas from this type of activity, but certainly the nicotine that's in there does cause damage to the tissues, creates genetic changes and downregulation of genes, as we'll see, that can go on to increase the risk of someone developing oral carcinoma. So we're seeing a huge increase, unfortunately, in adolescents who are using vaping products. It's starting to surpass cigarette use. Now, vaping, if you're going to make any positive comment about it, is that it has been shown to be a good way to reduce and take people off cigarette smoking and get them onto vaping, and then from vaping to go through cessation totally. But in itself is not certainly a good habit. So what's happening in the tissue level? Again, smokers and vapors have this deregulation or downregulation of protective genes. So in our bodies, we're always being exposed to certain environmental toxins and carcinogens. And every once in a while, those things will get into our DNA and start triggering the reaction to tell the tissue to start developing a cancer. So the cancer takes over, the cells grow without check, and then they go on to invade surrounding tissues with this abnormal development and then potentially spread metastatically to other areas of the body. When normal patterns occur, our body sees these abnormal DNA, they're able to clip these and remove them, and so we have a good amount of genetic protection so that most of us, fortunately, do not face the risk of a cancer. However, when we smoke, we'll start to see deregulation of these important genes. And when they look at it histochemically, what actually you can see about 1/4 of those deregulated genes are found in e-cigarette smokers as well. So again, there is that risk. We can tell our patients and counsel them that e-cigarette smoking is certainly not a safer way, and you are definitely at risk of that. Now, another question that comes up is, what is the relationship with human papillomavirus or HPV infection? So HPV there's about 40 different serotypes. The type that's most common, as you see in the last bullet, is, or the next last bullet, is type 16, which is associated with most of the oropharyngeal cancers. Now, there are some sort of rules of thumb about this, that the small verruciform or cauliflower-like appearing lesions that are more anterior in the mouth, say towards the tip of the tongue, ventral tongue, are almost unlikely to be a carcinomic or cancer-forming type, as opposed to those that form more towards the base of the tongue and in the hypopharynx. So the further down the throat that we see these verrucous lesions, the much more likely they are to be responsible for developing an oropharyngeal carcinoma. So HPV is spread through sexual contact, including oral sex. So therefore, that is the mechanism of transmission from someone who is infected to a non-infected person. Again, these viruses are indeed related to cancer. And as we say here, the cancer at the base of the tongue or in the tonsils is much more likely to occur. Fortunately, the development of the Gardasil or the vaccines against HPV are effective against HPV type 16. And so not all the serotypes are covered by the vaccine, but the types associated with oral cancers are. So it is one of the few vaccines that actually has a cancer preventative aspect to that. So besides the nuisance of someone developing, say, genital warts, which can be with them for the rest of their lives, and then, of course, transmit it to their sexual partners, they have less risk of developing an oral cancer as well. So there is a push by many organizations, the AMA and as well as the ADA, to recommend that young adults indeed be vaccinated at appropriate ages, assuming there's no medical contraindication to the HPV virus. Other more or less common risk factors are ultraviolet exposure. If you're in an area where there's a lot of outdoor workers, say farmers or other types that are outdoors a large portion of the day, the lower lip in particular is subject to continual hit by ultraviolet rays. Initially, you'll start to see thinning of the lip tissue and then developing sores. And as we talk about sores, we talk about areas that don't heal over a period of about 2 weeks, are those areas that give us a high index of suspicion. Other less direct causes, but associations with oral cancers, are diets rich in red meat, processed meat, and fried foods. So I'm going to change what I'm going to eat later tonight because that's part of my diet. Gastrointestinal reflux disease, or GERD, where the acid comes up from the stomach. A lot of times it happens at night when people are sleeping. The acid is a direct irritant to the surface tissues. And there was always that concern many years ago in history. It was always felt that the cancers were due to repetitive trauma on an area, and that theory has pretty much been ruled out. But certainly some of the chemicals, again, what happens actually affects the genes that protects us, and then therefore we are at a higher risk of an oral cancer should we get exposed to certain environmental carcinogens. Again, radiation treatment is certainly used to manage oral cancers in conjunction oftentimes with surgery and perhaps chemotherapy. Most oral cancers, and a little bit past the scope of our talk tonight, are managed usually by surgery as well as then radiation afterwards. But once someone gets radiation, I think we're all aware of the effect of osteoradionecrosis on the bone, and that they're at a higher risk of non-healing should they need dental extractions or develop sores from their dentures, etc. And not common here in the United States, but certain other types of habits, such as chewing betel nuts, it does increase, and it's a direct carcinogen as well. And then depending on your work, if you're exposed to any type of formaldehyde, asbestos, or sulfuric acids. So Dr. Lingen has written quite a bit about our diagnostic tools, and I want to speak a little bit about some diagnostic aids for the detection of oral cancer. Most of it is going to rely on our eyesight and that of our staff. So we want to train our staff and be sure that they're doing a full clinical examination for oral cancer every time that we take in a patient, and certainly at every 6-month interval. Obviously, we're going to focus a lot more heavily on these high-risk patients, but every patient should have a full screening. It's pretty simple. Pull the tongue out with a piece of gauze. Make sure we look down the ventral surface or underside of the tongue. Look side to side. And also retract in the cheek area and look behind the last molars, the retromolar area, and the floor of the mouth. And these are the areas that, if carcinomas are going to form, that we're most likely to see those occurring. Now, are there any aids? There are some products out there and some techniques, and I'll mention a few of those tonight. We can certainly, though, mostly is going to be a focused clinical examination. So we're all well trained at looking in the mouth. We've seen hundreds and thousands of mouths in our lifetimes, in our practice lifetimes. So it may be helpful, but we may not see all potentially pre-malignant lesions. So it's important that we do verify and follow this closely with patients. There are some aids to cancer screening. I'll mention a few comments about a brush cytology or brush biopsy. There is some helpful with that in diagnosis, but we'll look at our decision tree on who we treat and who we refer and see where brush biopsies may come back in there. But the main take-home point on brush biopsies is that it's useful for someone who's non-compliant, who's unlikely to come back for a follow-up exam, or accept a referral to someone who may do an actual blade biopsy for that person. So with a brush biopsy, what we're doing pardon me, is scraping some of the surface layer off the tissue that's collected in that bristle brush. It's then placed onto a microscopic slide, a fixative is applied, and then it's sent off for the laboratory for investigation under the microscope. And this is very analogous to a Pap smear, which can be done to look for cervical cancer in female patients. Now, the problem with the brush biopsy from the pathologist's point of view is that they don't get to see the normal maturation pattern. So if you look on the right portion there where you see the cell layers, when a pathologist sees a section of tissue that's removed with a blade, they're actually able to see the deeper tissues, the basement membrane, and then they see what's called a normal maturation pattern. So immature cells at the bottom move up to the surface, they mature, they then slough off, and then there's this constant renewal or rebuilding of cells in that area. With the brush biopsy, though, you're just collecting the surface cells, and they cannot tell if there's any changes in the maturation pattern. So when there's a disturbance in maturation pattern, it's often called dysplasia. So there's no mitotic figures, there's no abnormal appearing cells, but in dysplasia, what we see is a change in the typical pattern from immature to mature at the surface. So that's a big tool that the pathologist does not have when we just scrape some cells. So certainly a brush biopsy can test for malignancy. If there's a good collection of cells and there's actively shedding tumor cells that are frankly carcinoma of the squamous cell tissues, that will show up. But many times, and I would say when I was doing a lot of brush biopsies, my results would be about 75% of the time would just say that there appears to be some abnormality, and confirmation with a conventional biopsy is indicated. So we really didn't help ourselves very much. We didn't help the patient. There was this delay potentially in diagnosis. Perhaps we lost track of a patient. And as we deal with the medical legal aspects of these cases, once we have a patient that we're concerned about an oral lesion, and if we do obtain a tissue sample, it's really incumbent upon us to follow up with the patient should they even be reticent to come back. So very low benefit in our practice nowadays with the brush biopsy. Perhaps if someone's had a previous history of malignancy, and the areas still look a little bit abnormal to appearance, then perhaps a brush biopsy may be useful in that case, but in general, it's not something that we utilize very often. So again, here's what you see on the bottom here. You see the brush biopsy instrument, basically a bristle brush, and it's not without some discomfort. So you say, I'm just going to swipe this along your tissue like a toothbrush, but we don't brush our mucosal tissues very much. So it is a little bit uncomfortable. And again, they'll see a mixture of those cells in the specimen, but they really can't line them up to see, are those basal cells really at the bottom where they belong, or those intermediate cells, have they moved up? So there's also was a trend many years ago to do what's called vital staining, where you actually took dyes, and one was toluidine blue, which is a very deep blue stain, and have a patient swish with it, and basically would highlight certain areas inside the mouth where the tissues are more exposed. And the thought being that the higher nuclear component of cancer cells would absorb more of the toluidine blue, and therefore you could see the lesions. And I would say honestly, it was somewhat interesting to use. I did it when I worked at a VA hospital for a little while, and I do recall one patient where he had a persistent lesion that I was convinced was a cancer, and every time I biopsied it, never came back malignant. I finally had him rinse with the toluidine blue, and it actually picked up a little bit higher concentration, a little bit more towards the floor of the mouth, a little bit out of my visual view, where I thought the lesion actually was, and that did actually show with a blade biopsy some frank malignancy. So we don't have full approval for that in the FDA. It's not easy to use. You have to have them rinse with acetic acid first, then rinse with the toluidine blue, and then go back and rinse again. And so it may have some promise down the road, and basically utilized sometimes for high-risk population. I think where many of us are trending now in utilization is tissue reflectance. And the theory here is that it's interesting that certain tissues will give off different types of fluorescent features based upon the normal nuclear component of the tissue versus potentially malignant or pre-malignant lesions. So some of the earlier attempts at utilizing tissue reflectance basically had a high sensitivity that they would pick up things all over the patient's mouth, but not a high specificity. In other words, it did not really choose or be able for us to detect an irritation type lesion versus a potential malignancy. But this has been further refined through what's called narrow emission tissue fluorescence. So it's a big fancy name, but basically there are some preliminary results that are promising. It does allow us to identify potentially some pre-malignant lesions versus some innocent lesions, or also look at some areas that look to be undetectable by visual extent. And I think using that example I mentioned, my patient at the VA with the toluidine blue, this type of utilization a device would have allowed me to see this other area that maybe would have driven my biopsy into that spot and would have allowed me to get a diagnosis about 3 or 4 months sooner. So there are ongoing clinical trials in utilization, but this is something, and I have a few slides about that in a moment. So basically, where are we in our differential management? Again, the first start is our observation of the patient, our full clinical examination, where we're going to use conventional visual exam. We're going to pull the tongue out of the patient's mouth. We're going to look around. We're going to push on areas to feel if there's any areas of induration or firmness that should not be there. We'll also feel along the head and neck area, underneath the chin, underneath the jawline, to feel if there's any major abnormalities such as lymph node enlargement. And of course, what the best thing to do is palpate both sides of the patient's neck at the same time, because if someone has a large, say, submandibular gland on one side, more likely than not, it'll be the same on the other side. And the submandibular glands, the parotid glands, can certainly have intraglandular tumors, and they will present a certain nodules within the gland itself. Again, we'll talk about some adjuncts that we could use to clinically and evaluate and triage the patient. If on the right side you see if there's a negative result, then it's a low probability of having a problem, and that therefore we'll follow up then to confirm that with this negative result and then observe the patient. But if it's positive, then I think, again, histopathology and biopsy is very important. Again, we're working in the oral cavity. Yes, there are some major nerves and blood vessels, et cetera, that are somewhat deep, but in general, we can get a superficial biopsy, and if you're comfortable doing some minor surgical procedures in the office yourself, they certainly fall within the realm of our clinical practice. Now, this is a nice device, and this is that narrow field emissions called a Gocklies. And basically what it utilizes is something that we probably all have in our offices, which is a curing light. So this works with any curing light that's out there. That's not any particular brand specificity. You do, of course, get these goggles. And what it does, it allows highlighting of the normal tissues to undergo this green reflectance. And that's why the glasses are green, because they block all the transmission of light except for the green color. And areas of malignancy or abnormality will show up dark in the field of green. So if you look at the center picture, it's sort of highlighted there, that dark area, and that would be an area of an index of suspicion. And we look at the clinical picture, yes, there's a little area just right on top of the alveolar ridge, but it's hard to appreciate the extent of it into the vestibular region along the buccal aspect. So this is a nice device that's out there to use. And basically, this is just how it works. It's basically your curing light will emit light in the range of 390 to 500. And basically, you keep it, just a few millimeters up from the tissue. It allows the tissue that's normal to reflect, and it'll transmit off this green light, where the malignant tissue or neoplastic tissue does not reflect it the same way due to the different concentrations of some of the agents, particularly what's called FAD or flavin adenosine dinucleotide. So not super important that we know exactly how it works, but it does work. So again, you will not see the autofluorescence reaction in a malignant area, and it allows potentially for determining the site that we may wish to biopsy that patient. Also allows us to observe patients following any type of cancer removal to see if there's any risk or signs of any recurrence. So basically, when you see a lesion in the mouth or see a patient, you start with this area. So this is Dr. Lindgren's pathway that's published in the ADA Journal. It's a good article to pull up. It's available even for non-members to look up for free. And basically, if you look at A on the top left, no clinically evident lesion or symptoms. Okay, that's pretty simple. Therefore, no further action is necessary at this time. If there's a clinically evident but seemingly innocuous lesion, one that we don't suspect to be malignant, so it's a little sore, they bit their tongue or their cheek, again, periodic follow-up to determine if more evaluation is needed. You should see resolution on its own or certainly no change. So good to see the patient back. A 2-week window is usually pretty good. And most sores in the mouth will heal during that time. If a lesion persists more than 2 weeks, then it falls into our category C, which is a clinically evident suspicious lesion suspected to be either a pre-MD, a pre-malignant disease, or a malignant disorder. And that's where really obtaining a tissue biopsy really helps us, because we can pick up these PMDs or pre-malignant disease before they go on to change over to something frankly malignant and invasive. So if it is clinically evident, suspicious, or a lesion in B that did not resolve over 2 weeks, have the patient back. If you're comfortable, obtain the biopsy yourself, or certainly you can refer out to a surgical specialist that is maybe more comfortable. If there's a diagnosis of a pre-malignant disease, the options there are to watch the area or to consider superficial ablation of the tissue. And oftentimes in our practice, the use of the laser to remove the outer epithelial tissue to get down to some healthy tissue underneath it and allow it to heal secondarily. Now you see the dashed line dropping down there, should a patient decline a biopsy or referral. And that's a very complicated position for us. The patient puts us behind the 8 ball. We have a responsibility to explain to the patient that, yes, there is a lesion there. I may not feel that it has a lot of characteristics that makes me feel it's a malignancy, but it should not be there, and therefore it should be evaluated. And the patient says, no, I'm not going to get this done. I'm not going to go see that oral surgeon, or I'm not going to let you cut out a little piece of this tissue. Then in that situation, you could offer them the option of a brush biopsy, but that would be one of the few indications in that area. But a lot of times with a brush biopsy, we'll get a positive or atypical test result, which is that bottom area there on the left. And that basically just says that correlation with an incisional biopsy is indicated. So management of these patients can be difficult, dealing sometimes with older patients as well too. So incisional biopsy is certainly the way to go. unless the lesion is sitting right on top of the salivary duct or in some other area that is overly concerning to high risk of removing the tissue. Again, a small superficial incisional biopsy should be very straightforward for us. And the goal is when we obtain biopsies, if we have a tumor, we want to treat it early. We know, as we'll see, success rates will be a lot better. So we want to hear about the story of the lesion. Is it something that you noticed on your exam, or has a patient been monitoring this for a while? What does the patient say? Is it getting bigger or smaller, or just staying the same? Again, a thorough examination about the tissue. Does it feel firm and indurated or hard, which is a little bit concerning because as a tumor grows through the tissue and into the muscle, say into the tongue, it will basically damage that tongue muscle tissue, and then it'll just be very firm and hard. We can see an ulceration or a sore on the surface that just doesn't heal. And the type of tissue, whether it's mucosal, deep, and whether it's involving nerves or other types of structures. So most of the things we are going to see are inflammatory in nature. Some things are developmental, such as tori, for example. But again, we will see our share of neoplastic disease. Now, if you are taking an incisional biopsy versus removing the lesion, so the white area surrounding that tumor is what we would do to cut this lesion out, and what's called an excisional biopsy, or removing the entire thing. And many lesions are fairly small, so we just go ahead and remove the entire lesion. But if it's larger, we're just going to take a sample. If there's some generalized redness in the mucosa, we'll just take a sample. And for the pathologists, it's valuable for them to have as much of the tissue, especially some underlying normal tissue as well, so they can see those levels of maturation. So you want to take your biopsy margin directly from the middle of the lesion itself. If you can get a little bit normal tissue around the edges, that's okay. But the abnormal tissue and getting in a little bit deeper, so the underlying mucosa or muscle, depending on where it is sent as well too. You don't want to take areas right from the edges. So here's a fairly extensive lesion on the side of the tongue. Again, this is something the patient didn't even notice they had until it was pulled out their tongue and say, hey, look at this. And they say, oh, they're surprised as well too. Basically, I would describe it as a leukoplakic or a white lesion with irregular borders. It is somewhat firm. Now, it could be a reactive lesion. You can ask the patient, do you put a mint inside your mouth and suck on it all day on that side? If they're a pipe smoker, do they keep a pipe on that side of the mouth? Certainly, we would have a high suspicion of a malignancy, but something that should be evaluated. And certainly, we would want to obtain a biopsy of this tissue. We're not probably going to remove the entire lesion at this time. We're doing an excisional biopsy because it's fairly extensive. But we would pick an area, perhaps, just further in where it's really abnormal, and perhaps on the lower border where there's a little bit of normal tissue, but getting a good bit of that white tissue along with some of the deeper tissue. Now, the white lesions are a little bit easier to biopsy than the ulcerated lesions. So if you just send a sore or an ulceration, that's not going to show the pathologist very much. So in an ulcerated area, we do have to get around the edge a little bit. So when we take out this lesion here, this is characterized as an ulcerated lesion. And if you just took a little sample dead center of this lesion, it may not look very much. It may just be an irritative area. So you want to get some of the ulcer with some of that rounded, indurated tissue that's present around the edges. But, if the patient gave you a history of some local trauma, would not be a wrong thing to say, come back in 2 weeks. 2-week delay in diagnosis is not significant, and take a photograph of it, put it in the patient's record, so then you can compare it. And if it's getting much smaller, obviously that's a positive sign. If it's not, that's a negative sign. Oh, I went too far there. Now, many of the things we'll see are fairly obvious. This is an epulis fissuratum, obviously caused by an ill-fitting denture. It's very well organized, so even if you make the patient a brand new denture and reline it and what have you and relieve it, it still probably will be present. So it still may need to be surgically removed. And the question always arises that every time we take something out of someone's mouth, do we need to send it in for a pathologic or histologic examination? And obviously, we don't send teeth in. We know what teeth are, and they're going to show up not very significant on a pathology. But in general, removing tissue, if we're not sending it in for histologic diagnosis, then again, that mandates very close follow-up on our part. So one can make the case I was speaking in a program with someone who was actually a dentist on a malpractice company, and they don't send the simple lesions in if they're convinced it's just a fibroma, for example. But in our practice, we tend to send everything in. Another question or issue comes up is with apical surgery. So many endodontists feel that every time you do apicoectomy and you remove tissue, you should send it off for histologic diagnosis. But the converse is every time we take out a tooth that has a granuloma at the end, which is what most apical disease is, we don't send that tissue in for a diagnosis. So clinical correlation, should the lesion be there? Is the tooth endodontically involved? Is this lesion due to some local reason? And this is obviously a reactive lesion due to that. Now, in contrast, every once in a while, the zebras will show up. So, the old rule of thumb, if you hear hoofbeats in Boston, don't think of zebras. But occasionally, we will get a zebra, and this looks like a denture irritation, but actually turned out to be squamous cell carcinoma. And you can see some of the differences. It's an ulcerated area. If you were to push on this, it's very firm and indurated and hard. And yes, you can certainly treat it appropriately by cutting back the denture, relieving it, relining it, but having the patient back 2 to 3 weeks later to see if that alleviates this. Of course, leaving the denture out if possible is always a great cure, but many patients don't want to be without the denture for 2 weeks. So lesion that persists more than 2 weeks, again, should be biopsied. Now we'll see a lot of these vague changes in the tissues, some white areas. It's interesting that you can see here on the mucosal surface of the lip. Oftentimes this is due to utilizing mouth rinses. So patients who use mouth rinses that contain higher alcohol contents, and many of the over-the-counter mouth rinses like Listerine and Scope, et cetera, now have an alcohol-free variety, because it's interesting, patients can use an alcohol-containing mouth rinse for many, many years, never have a problem, and all of a sudden they come in and they develop these white reactive lesions. And when we biopsy them, they just show thickening of the tissue, hyperkeratosis, analogous to a callus that you might have on your finger if you were playing guitar or doing a lot of woodworking or something like that. So something that's innocent. This could be observed. It's not ulcerated. The tissue's not firm around it. But again, you'd want to see the patient back at least 2 weeks to make sure that it's not getting bigger or that it's resolving. And again, taking a biopsy from the area is a very low risk to the patient, low morbidity. And so one would consider, doing that. Now, some lesions are very large, and this is problematic to the patient, but you can see the bluish color of it. When you squeeze on it, it blanches, so we are comfortable that it's a venous malformation. So you have veins that circle around the oral cavity, especially around the anterior part, that will form venous lakes or a little ballooning of the veins, and easily to diagnose by pushing and pressure on it. You see it blanches and goes away. However, a lesion that doesn't blanch, doesn't go away, may make us more concerned for potentially like melanoma or other pigmented type lesions. So something that probably wants to get removed because it's probably going to be interfering with the patient when they bite and chew, and they'll probably be more comfortable having it removed. But may have a little bit high vascularity, and again, may require not life-threatening bleeding, but controlling of some oozing. Being venous, it's not going to have an arterial blood flow to it. If you can feel pulsations, obviously that's a different situation there. These are the tricky one. It's a little subtle, but if you look at the right portion of the lower lip, it's kind of firm. The history of this patient is a farmer who works outside quite a bit, tends to get recurrent sores on his lip, and this is a very firm area, very indurated, and he feels it's been getting a little bit larger. He bites it now a little bit occasionally, and again, this is something I have a higher concern with a high risk factor of a development of a skin cancer or a lip cancer, and should definitely be evaluated with incisional biopsy. So the lumps and bumps that we see there, most of these are very innocent. Again, we'll get a call, I'm sure you do once or twice a year, from a physician's office. Patient's here has got this big mass on the roof of his mouth, and maybe it got a little irritated, and of course it's a torus palatinus. On the buccal mucosa in the middle there, a little fibroma, and you can see that also on the lower screen on the right side as well too. And so these are mostly reactive lesions. Good explanation: patient bit their cheek at some point in the past, it healed, it shrunk down, never went back to normal because it's a little bit enlarged. Every time they bite and chew, it gets irritated again, slowly continues to enlarge. So the technical name of a traumatic fibroma. So again, not a malignant disease. one that when they're this well organized, they're not just going to go away on their own. So it is something that, recommendation of treating those are certainly, important for removal. Now, these look very ugly, and both of these turned out to be pyogenic granulomas. Again, we can typically trace a source back to some dental issue. So on the left side, there's a tooth there, and it's actually an implant tooth, and underneath it was one of those plastic scaler tips. So the plastic scaler tip had broken off when the hygienist was cleaning around the implant. It was left behind. They probably noticed it was gone, but just said, oh, it probably got picked up in the suction, but it wasn't. And so as it sat there, it irritated it, created this reactive tissue. So we need to remove the source. So pyogenic granulomas themselves are not a true neoplasm. They're a reaction to something. On the screen on the right side, the picture on the right, there's a fairly significant dental caries there. And it's a little bit of the pulp actually coming through and infiltrating and irritating that area. So as dentists, we have the lesions. We can look at the source. Sometimes it's an odontogenic source for the problem as well, too. Some of these are nice, firm, and hard. Obviously, they still need to be detected as far as what the problem is. They'll show up radiographically as calcified masses. These are ossifying fibromas, and oftentimes felt due to exostosis that we'll see. People who clench and grind seem to build up a bit more exostosis, especially along the lateral aspect. Again, nothing that's dangerous, usually does not need treatment, but when they get this large, they're bothersome to the patient, they're constantly irritated, and removal will definitely help the patient out. Now, I think the other most common thing that we see are the lesions of the lower lip, or mucus retention phenomenons, or mucoceles. Basically, these are not true cysts or neoplasms, but basically they form because we know the lining of the oral cavity is lined by minor salivary glands. The salivary gland pore gets blocked. The fluid, instead of coming up on the surface, dives down underneath there, creates an increased swelling until the pressure builds up enough for it just to break, or the patient bites it and it drains. And typically they go down, they come back up again, and they form. And you see on the left side, that's a unique one. It's on the ventral surface of the tongue, and that's a cyst of glandular. And so they're a little bit interesting. They're difficult to treat. You really have to get in there. So mucoceles, we don't try and excise out the entire cyst because it's not a true cyst. There's no true lining. You do is incise over it. The lesion will deflate, and then you need to make an incision, take out the little minor salivary glands that are in the field. They're about the size of a small BB. Oftentimes with the laser, that can seal the tissue up. Occasionally a suture or two is necessary to get some primary closure, but they usually go on to heal very well. Now, we will send mucoceles in for histologic examination, but they're fairly straightforward in presentation. Looking at the tongue, again, the top of the tongue, or the dorsal aspect, is an area where we almost never see malignant disease occurring. Again, this is known as a geographic tongue. It's basically, if you took pictures of this every day and made a constant movie out of it, you would see this moving around, so that's the term geographic. And again, can be bothersome to the patient. Some patients are bothered by its appearance, but one that we can make a clinical diagnosis on observation without the need for getting an incisional biopsy. So there are many things we can just reassure the patient that is a normal finding. The hairy tongue as well, too. This is sometimes a response to antibiotics. It also can be a marker for HIV infection. So having a discussion with the patient, and as far as any risk factors for that. And then also patients that utilize, you'll see this sometimes with the use of the chlorhexidine rinses, will start to develop the same pattern, and sometimes just lightly brushing or wiping gauze along the top of their tongue. And just some individuals have deeper filiform papillae on the surface of the tongue. They collect more debris. The cellular debris just builds up, and when they use chlorhexidine, it basically just stains it, and it's sort of a marker for that material. Now, in the center there, you see this median rhomboid glossitis. Again, just a loss of the normal filiform papillae in that area. I'm actually a little bit more concerned about that area on the right side, where it's more of that circular region. Again, it's very uncommon for us to see malignant disease on the dorsal or surface of the tongue, so it's just something to be aware of in that area. Now, some other lesions look very bad, but they're generalized throughout the oral cavity, and a malignancy in itself would not present this way, but this is oral candidiasis. This air is following an antibiotic course for this patient. And basically, if you took a piece of gauze, it wipes off. There's underlying red and bleeding tissues underneath it. These will respond very well to topical antifungal agents such as nystatin. They heal up fairly quickly, but they're sore, they're bothersome to the patient. And also some patients will be subject to this if they're immunocompromised, perhaps undergoing chemotherapy treatment. Again, bony lesions, something that oftentimes we just see showing up on radiographs. They can be fairly extensive, associated with impacted teeth. They can be periapical lesions. And so the key is if we have a radiolucency, as you see there, say between the premolar and the first molar, is there a reason for it to be there? Is it an endodontically involved tooth, the premolar or the molar? Or is it a finding that's just a pickup on the radiograph that might warrant further investigation? Of course, malignancies can show up, but they typically don't form very direct, and I'll show you one towards the end. So we should know our cysts. Most of them are associated with developing teeth. They can prevent the eruption of teeth. They're typically epithelial in origin, and when you describe them, are they unilocular, just focused around the tooth, or are they mixed and radiopaque? So we'll just conclude with this case here. And again, it's always important to listen to the patient's concerns or the family. And this was a call that the pediatric dentist received over a weekend that my son's teeth on the bottom are loose. And of course, being a pediatric dentist, they just naturally assume they're the primary teeth that are loose and say, oh, that's good, have them wiggle it and they'll come out. And when you see the patient did come in the following Monday for a radiograph, and that's certainly fine that the patient was seen on a timely basis. But you see how the second premolar is really displaced out buccally and posteriorly. There's a loss of normal bone architecture in this area. And this actually turned out to be a Burkitt's lymphoma in the bone. So, we will see some signs of systemic lymphomas and leukemias. They can certainly affect the oral tissues. And typically patients will also present what's called constitutional signs, or they're also known as B signs. I'm not really sure what the B stands for, but they're called B signs. And basically night sweats and fever, loss of appetite, and malaise. So somewhat vague kind of concerns. But, if the mother says, the kid is usually very active, he runs around all the time, he's just been laying on the couch for the last 4 days and running a low-grade fever, and you see a radiographic finding, this obviously mandates some more deeper investigation and management of this case. So I just want to conclude by saying we talked about the risk factors, and it's interesting that oral cancers is typically a disease that will affect older patients 50 years and older. So that's obviously one of the risk factors. The tobacco and alcohol user obviously has a high rate of concern as well too. What key thing is that early diagnosis, you can see the survival rate of stage 1 disease or very localized lesions is quite high, 94%. We can see those lesions, we can cut them out, we can decide if they need radiation, we can see if they need any neck surgery, etc. But that survival rate is very high. That's the great news. The bad news is that this survival slide would be the same slide I would have shown you in 1980. So our survival rates, our success rates in management of oral cancer has really not increased over time or improved. Now, their patients are more aware. There's probably less people smoking and drinking. But unfortunately, most oral cancers are found in stage 2s and 3s. And so there you see the survival rate drops off quite dramatically. So again, we have a great role to play in this battle. I think the dental professional is an important key to the reduction and better improvement of outcomes in life, and so success in its treatment. So, we go back to our office tomorrow or later tonight. Make sure we're examining everybody. We're looking carefully. If we see something that doesn't look right, it's the old, if you see something, say something, and that certainly applies to oral cancers as well too. So again, I thank you all for taking time to be part of this program. I think it says a lot about your commitment to your patient care. I see we've gotten a few questions through here. And so one question comes through about from an oral pathologist, says that says that the effectiveness of the HPV vaccine is uncertain. Well, I would tend to disagree with that comment. Again, not all of the HPV serotypes are prevented or vaccination proven, but the HPV 16, which is the primary one. So when we don't typically, if I take out a verrucous lesion on the tip of someone's tongue, they'll just report it as verrucous vulgaris, and that's the end of it, and we'll observe the patient, remind the dentist, if they're referred to us, to check the patient for any recurrent lesions, and that's the end of it. But when we have carcinomas in the base of the tongue, in the posterior, in the pharyngeal areas, and there's viral modification, those are tested, and it's, again, almost without exception, HPV-16. So the HPV oral cancers is what's taking over now as our primary carcinoma, and certainly it does work. So another question is, what do you tell a patient who wants to send a sample to a general pathologist who's in network and not the oral pathologist? That's a great question. And so that's been a comment that's come up a lot. It's the management part, and sometimes it's an issue too from our practice if we don't provide for that patient's medical plan, and the dental plan doesn't want to cover it because they feel that it should be covered under the medical. So it is a battle that we face. I think it's one that we need to deal with and let the patient know. I had a patient where I sent off the sample at the hospital. The pathologist there wasn't comfortable reading it and sent it to an oral pathologist, and the oral pathologist, then ended up with a bill, and the patient did that they weren't expecting. So it's complex, and I'm sorry I don't have a great answer for that other than trying to deal with his issues. Michael Perry asked about advancements with salivary markers and oral cancers. Yes, indeed. In fact, there is an article in this month's O talking about salivary markers. So I think as time goes on, but the question is, we still need to see the lesion, remove the lesion, and even if you have a biomarker that is suggestive of an oral cancer, you still have to find the primary. And that happens in medicine and oncology management, that sometimes patients have a lesion somewhere and it's not the primary site, and it's difficult for them to find the primary. So with more imaging techniques now, the PET scans, photon emission scans, we're able to see things that we could not see before, deeper in the body. But again, with oral cancers, these are up front, up on the surface, and able for us to evaluate. And then finally, we'll take one last question from Dimi, which is, how useful are punch biopsies? And so, again, a punch biopsy taken in the center of a lesion, as long as it's not just an ulcer, I think will be beneficial, better than certainly a brush biopsy. Again, the goal is to get the pathologist a stratified layer so they can look at it sort of like the rings of a tree, and they can see the submucosal tissues, the basement membrane, and then the epithelial tissues, because, again, these oral cancers, the squamous cell carcinomas, are epithelial or surface tissue lesions. And if they can see those lesions, then and they can see those tissue layers, they can give you a good diagnosis. So they may come back, and we see this a lot in our practice, of a diagnosis of, quote, dysplasia. And dysplasia just means that it may be a pre-malignant lesion that needs continued monitoring, maybe not about additional surgery or treatment, but, again, close observation, and we're not really sure how often that is. Okay, so let me see if there's any other. So someone asked about the specificity and sensitivity of the Gottlieb's. So that's a good question. Again, more and more studies are coming out. I've had the chance to utilize it as a tool. It does show you some extensive lesions that you may not have seen how far they actually extend. Again, oral malignancies are still somewhat rare, so it's hard to get 100 patients with a cancer and 100 without and see what the Gottlieb's or any of these emission-type devices actually show. So it does offer some promise. Again, I've had some experience with these hidden cases that are a bit more occult. But again, I think our two eyes and observation and feeling are going to be our primary tools. But there is definitely interest in this, and I think it's something that, as studies and work becomes further refined. So I would say, directly answering your question, the sensitivity is quite good. The specificity sometimes is such that we don't want to tell the patient, oh, it looks like you have an oral cancer there. But you do tell the patient you have something that looks a little suspicious. I think we should get this checked out. And whether you choose to do the biopsy or you choose to follow it or you want to refer it, I think that's the appropriate. But we don't want to get the patient too agitated because, again, sometimes it's just a minor irritation that will go on to heal on its own. So, again, I want to thank you all for your focus on your patient care. I think, again, it's a very commendable and states a lot about the nature of how you practice. I'll turn it back over to our program to get our post-test and allow you to claim your CE credit, and wishing you all the best for a healthy and happy summer. Take good care.